We need to take note of the ways that hospitals relate to a couple other key parts of the healthcare system. First, sometimes hospitals employ physicians directly. They hire the physicians, and the physicians work in the hospital. They function then as one unified organization in that way. This is, for example, a common way hospitals and specialized physicians work together in the UK, and it's actually becoming more common in the US. But that's not always the case. The second way physicians and hospitals can be related is where physicians set up and run their own practices, but then make arrangements with the hospital to be able to work and provide medical care there. As a piece of terminology, we might say that these physicians have admitting privileges at the hospital. A physician might apply to the hospital and, if accepted, be given privileges that then allow the physician to take care of patients in the hospital, come in and use the facilities and provide services there. But the physician practice and the hospital would still be separate entities, separate businesses that are organized and probably paid separately. This arrangement is the more common one in the US. A second relationship we should talk about is between hospitals and intermediaries. Hospitals need arrangements with the intermediaries to take care of covered patients and arrangements for getting paid when they do that. This can go a few different ways depending on the country and the healthcare system. In some cases, maybe where there are fewer intermediaries or even one large and dominant intermediary, there may be a pretty well understood and stable set of expectations about which hospitals and which intermediaries can expect to work together. They may still have to work out the particulars of payment agreements, how and how much they're going to be paid, for example, and maybe other rules and procedures from time to time, but who's working with who will have some stability to it. In other cases, though, it can be a little more fluid. In particular, where there are multiple intermediaries and many private hospitals, as is the case in the US, this can get a little more complicated. In this case, hospitals and intermediaries may have more flexibility in making arrangements to work together and figuring out which hospitals are going to be in the networks of which intermediaries. Intermediaries can approach this in different ways, and that will affect the hospitals. Some intermediaries will aim to take a lot of hospitals, even any hospital meeting some criteria they may have. In this case, hospitals might just need to enroll, meet some standards, show their accreditation, for example, but then they'd be accepted by the intermediary to take care of the patients. However, most intermediaries in the US, private insurers in particular, make specific contracts with individual hospitals that provide for the given hospital to take care of patients from the intermediary. These agreements would also specify terms for payment when the hospital does take care of the patients. That hospital then would become part of the insurer's hospital network, and we refer to the hospital as an in-network hospital. Note that any given hospital in this scenario may make arrangements with multiple intermediaries and be in-network for many insurers, or maybe just a few, depending on the preferences of everybody involved. So, a couple important relationships involving hospitals that we need to keep our eye on.